I'd like to welcome Mr. Nick Panay to join me. Today's session is all about menopause and long-term health, something I'm very passionate about. For those that don't experience any symptoms at all, then that's absolutely fabulous. But this is a time when we all need to concentrate and think about our long-term health. So Mr. Nick Panay, gynaecologist with a special interest in women's health, director of hormone health. So Nick actually sees individual patients, and I should say the special prize today is a consultation with Nick. So very, very special gift there. And he's also the president-elect of the International Menopause Society. So welcome, Nick.
Thank you very much, Deborah. Thank you for having me again.
Again,
always a pleasure.
Back, Henpicked favourite. And we are going to focus on long-term health. So first of all, Nick, could I ask you to summarise what's different, what's going on in our bodies? Why do we need to focus on long-term health at this time?
Well, I think we need to focus on long-term health from the minute we're born. But, and you know, it's a life course approach, isn't it? Through school, university, the workplace, and beyond. And I'm delighted that menopause is now going to be included in the school curriculum. I think that's so important. So when I was chair of the British Menopause Society, goodness me, nearly a decade ago, one of the important changes that we made or asked to be made by the Department of Health was for menopause to be taken more seriously and to enable women to be able to go to their primary care physicians, their healthcare professionals, practice nurses, to talk about menopause, because menopause is now a midlife point. You know, I like to refer to it as middle youth. And I think it's a great time that we can start to really focus on making sure that the second half of our lives is healthy, at least as healthy, if not even healthier, than the first part of our lives. And you know, a lot of the stuff that we talk about is not rocket science. It's important to make sure that the diet is as optimal as possible, that we exercise regularly, that we minimize alcohol, that we don't smoke. These are obvious things. But it's also an opportunity to talk about hormonal options and alternatives, complementary therapies, etc. And I think the most important thing is something we were talking about earlier, Deborah, is that people have the opportunity to obtain bona fide, good quality information so that they can make a choice that's right for them, an evidence-based choice. We talk about empowering women to take control of their own lives, and that's really what we want to try to achieve. And
whilst we may be trying to be healthy all our lives, and usually mine starts next Monday, during menopause, our bodies go through significant changes, doesn't it? So do we need to be more careful during and after menopause?
So the key changes that take place during menopause are due to loss of ovarian function. So what causes menopause? It's the loss of follicles, loss of eggs in the ovaries, which means that the periods then stop and estrogen levels decline. And we know that there are hormone receptors throughout the whole body. So the classic symptoms of menopause, of course, are hot flushes and sweats, disturbances in sleep, which occurs due to declining hormone levels impacting on the hypothalamus, the lower part of the brain. Sometimes there can be brain fog, sometimes there can be low mood. But because there are hormone receptors not only in the brain, not only in the parts of the body that cause these symptoms, we also have receptors in the bones, in the heart, in the muscles, in the cartilage, in the bladder, in the vagina, all of these areas where the loss of estrogen potentially can have an adverse effect. And what's becoming clear is that the degree to which somebody is affected is probably genetic, but doesn't always necessarily follow in terms of your family history. So I'm often asked, well, if my mother had a good menopause, does that mean that I will have a good menopause? And unfortunately, that's not necessarily the case. You've got a better chance of having a good menopause, but it's not a guarantee. And so
you can get symptoms. Sorry, you mentioned some of the symptoms there, and the long-term health symptoms are the ones I think can be. I know I had a woman in one of our training sessions last week, and she was saying, "I've had no symptoms at all. Why do I have to think about changes in my hormones? Will it make any difference to me?" And we talked about bone health and heart health, because you mentioned the bone health receptors. What happens to our bones during menopause?
So we've talked about immediate symptoms, and then there are intermediate symptoms, like the bladder and the vaginal changes. But in the long term, potentially, if we don't look after our heart, if we don't look after our bones, then there can be a decline in health from those perspectives. So in terms of, you mentioned the bones, the bone is it's a dynamic organ. It's not an organ that's standing still. So bones are forever being broken down and then reformed. There are these little bone remodeling units that are forever active. And we know that as estrogen levels start to drop, there is an increase in what we call osteoclastic activity. So the little Pac-Man comes along. It's a little cell called the osteoclast and eats away the bone. And the osteoblast, which normally puts the bone back, cannot keep up with the breakdown in bone. So what ends up happening is that you have net resorption of bone, so bone loss. And we know that that accelerates during the menopause transition, such that prior to that, there may be a 0.5 to 1% loss of bone density per annum, whereas during the menopause transition, that might go to 2, 3, maybe even 5% loss of bone density per annum. We know that bone density reaches its maximum peak, usually in late 20s. So as ovarian reserve starts to fall beyond that, then bone loss starts to fall. So that's why it's important to start even before menopause in terms of exercise, in terms of diet, making sure that all of those are optimal, making sure we have enough calcium and vitamin D, particularly in the diet. Other minerals are important as well, zinc, magnesium, etc.
Absolutely, because I know osteoporosis is one of my fears. It was something I saw my grandmother experience, and now one of my aunts has it. And for her, she had a fall, and just a couple of years later, never been to the doctors before, such a healthy woman. She had the fall, and we always say had the fall. She fell over and broke her hip. And the decline has been quite marked. Her height, she's having to take special medication to build her bones back up. It's had a dramatic effect on her.
Yes, I think the effects of osteoporosis are underestimated. And remember that without any intervention, statistically, 50% of women will be osteoporotic by the age of 80 because of the bone loss that takes place. But the good news is that we can prevent that, we can reverse it. There are treatments, hormone therapy and alternatives, but prevention is better than treatment. And we don't want fractures to occur before we instigate treatments. And the commonest fractures, you've mentioned hip, include vertebral fractures, so back fractures of the spine, and also the Colles fractures of the wrist, which occur due to falling on an outstretched hand. And in terms of preventing that, we've got to keep the bones strong and healthy. So we need to make sure that the bridges that hold the bones together remain connected. We need to make sure the bone remains dense. But we also need to make sure, and people forget this, that we prevent falls as well. Mm. And your team is passionate about menopause in the workplace, making sure that both home and the workplace are safe in terms of preventing falls. We need to make sure that the muscles are strong. So exercise is not only good for keeping the bones strong, but also keeping the muscles strong so that it keeps us up, they keep us upright. And if we do fall, there's more padding there to prevent fractures from occurring. And also minimizing things like alcohol and smoking, which can make osteoporosis worse. The other thing that's really important that people don't realize is to make sure that unless you're on a hormone modifying treatment, that the periods remain regular. And if they don't, then get them checked out sooner rather than later, because the loss of periods in younger life could mean that there is a loss of estrogen, which can then mean you don't achieve your peak bone mass. And it means that you then are more prone to fracture later on.
Absolutely. Of course, the theme for this year's World Menopause Day is early menopause. So for those experiencing menopause even earlier, it's even more important to get help and support.
Absolutely. Absolutely. Thank you for mentioning that. World Menopause Day, 18th of October. The subject of the International Menopause Society will be premature ovarian insufficiency, which is early menopause before the age of 40. And if you don't replace hormones adequately up at least until the average age of the menopause, which is 51, then potentially it does put you at an increased risk of osteoporosis and cardiovascular disease, possibly even Alzheimer's as well. So it's really important that issue is addressed early.
Thank you, Nick. And when you say, you mentioned the heart, cardiovascular, what are the extra risks during and post-menopause?
Well, menopause is a time where the metabolism is not as good as it was, potentially. So what does that mean? It means that as estrogen levels fall, insulin levels rise to try to control blood sugar in the circulation, and that can lead to fat deposition in the trunk as a whole, but particularly within the waist area. And we know that's metabolically unhealthy. So this is often associated with a change in the blood fats as well. So there can be a rise in the bad type of cholesterol, which we call LDL cholesterol. There can also be an increased risk of thrombosis, blood clots. And that's why it's important that things like smoking and weight are minimized to avoid those, and that we remain as mobile as possible. And we also know that the blood vessels can become stiffer. There's less what we call compliance, they're less flexible. And that's why we need to keep an eye on blood pressure, and we need to make sure that through appropriate dietary interventions and hormonal replacement, that in people who have a predisposition to heart disease but don't yet have it, potentially we can prevent that as well as treating it, but we'd rather prevent than treat.
Thank you very much, Nick. So if it was coming to a summary of the key things that we should be doing, it sounds like a lot of things are what we should be doing every day. So looking after our diet, our exercise, cutting out smoking, taking supplements to build up our bones if needs be, or to make sure we're absorbing all of the nutrients. Talking to a professional like yourself around HRT and what that could do for you too, particularly if it's early menopause. Is that right?
I think you've summarized it beautifully, Deborah. It's about going to have that conversation with a healthcare professional to make sure that you've got everything in place to prevent these long-term problems. And if you can't prevent them, at least minimize them and make sure that we can intervene if we need to sooner rather than later where required.
Absolutely. Nick, I'll ask my colleague Sally to join us in a moment because I can see some Q&A. But one of the things I would mention, we're getting a lot of people on our training sessions who are waiting until COVID's over to get help and support. thinking that the doctors might be too busy. But we know that for the vast majority, menopause can be diagnosed on symptoms alone. I know you're doing a lot of Zoom consultations, aren't you, in hormone health? How does that work?
We've turned very much to telephone and video consultations where we can do that. So unless we actually have to physically examine somebody, which is the exception rather than the rule, we can carry on doing the consultations. And I know a lot of healthcare professionals in primary care, doctors and nurses, are also offering consultations by telephone. And it's so important that during these times where perhaps we don't have the same levels of freedom that we did before, that if we can't exercise outdoors, that we exercise indoors, that we try to watch our diets as much as we can. And yeah, don't let problems fester. You know, go along and get these things sorted out, even if it's virtually rather than face to face. Because as I say, it's better to prevent rather than going along once a problem has happened. So there's no reason why looking after yourself should stop. And in fact, this is an opportunity to think more about one's health, because I think if nothing else, we've seen that the healthier we are, the less chance that this horrible virus can have an adverse effect on us. And so that is yet another reason why we should try and remain as fit and healthy as we can.
Absolutely. Actually, one of the colleagues at one of our sessions took our advice and went for a telephone consultation. And she said it was easier than trying to do the appointment lottery. I was actually just moved away from my desk, did the consultation, and then went back to my desk. It couldn't be easier. So I think our key message is don't wait. So over to you now, Sally. Have we had some questions in there?
Yeah, I mean, we've had quite a lot on early menopause, which you've very kindly already answered, Nick, around the long-term effects and the considerations around that, which is brilliant. Someone has asked, they said that it seems to be very hard to get diagnosed as having perimenopause if you're under 45, and whether some GPs can sometimes be a little bit maybe dismissive or not recognizing that that may be a challenge. And I think your point around if you're not having periods regularly, even if it's at an earlier age, that this should be checked out.
Absolutely right, Sally. And in fact, that is one of our key messages from World Menopause Day, that if there is irregularity with your periods, that this should be investigated sooner rather than later. It should not be accepted as being normal. I don't want people thinking that, if they're over the age of 45 or, approaching their 50s, that they need to have hundreds of tests to tell them that they've got menopause. If you're having hot flushes and sweats and you're in your late 40s, then the likelihood is that you've got menopause, and that can be treated without any investigations, according to the NICE guidelines that we've prepared. But where there is doubt about the diagnosis, so in that, certainly before 40, and also in that early bit between 40 and 45, if there's any doubt, then I think appropriate history taking coupled with targeted investigations, if required, will then enable us to give the right advice and treatment if required.
Excellent, thank you. And I've got a question around HRT saying, would you advise to use HRT as soon as you believe you're in perimenopause, or try and manage yourself by a healthy lifestyle for as long as you can before considering HRT?
So that question, the answer to that question is going to differ from person to person. That's the art of individualizing treatment. And that's why it's so important that if there are such questions, that that woman gets assessed by a healthcare professional with the information and knowledge to be able to support her in making the decision that's right for her. So there seems to be some reluctance, for instance, to start hormone therapy in women that still have periods. We know that the majority of women actually start to get symptoms whilst they're still having their periods. So it doesn't make very much sense to wait for the years it can take sometimes for the periods to stop completely before treatment is considered. It can be a bit more tricky because you have to time it according to the cycle in terms of when you start the HRT, but it's perfectly possible to do that. On the other hand, if somebody is going through the perimenopause, but they feel perfectly well, they don't have any risk factors, just, the period's a bit erratic, but they're in that late 40s, early 50s group, then they can wait it out and see what happens. They don't necessarily have to go on to hormone therapy. And where there's doubt, for instance, if there's a family history of osteoporosis, or if there's a history of erratic periods early in someone's life, or smoking or alcohol, or other things like steroids, for instance, that can increase the risk of osteoporosis, then we'll organize a bone density scan as well. And that will add to the information that we use in deciding whether somebody will benefit from hormone therapy as well, not just from the quality of life perspective.
Absolutely. And I think that point about the individualized care and that individualized focus is that one of the things we talk about a lot with women is every woman's journey is different, and it's about finding the right appropriate treatment for you in terms of what's where you are and where your symptoms are, and actually having, as you say, that conversation with a healthcare professional around what are your options and what would be the right choice for you. Any advice on how to have that conversation with the GP? Because we've got a few people saying don't feel they're really getting anywhere with their GP in terms of how the treatment that they want, or just any advice on how to manage that process.
Well, the first thing to say is, as we were saying earlier, you need the right signpost to get through that menopause maze. And if those signposts are not being put up for you, then you need to find somebody who will do that for you. So if you've approached your GP and you're not finding that particular individual being particularly sympathetic or helpful, then most practices have a number of GPs now that work within them. Make an appointment with one of the other GPs. And there is usually a GP within each practice that has a particular interest in women's health issues and menopause. That's not always the case.
No.
And if that isn't the case, then you're perfectly at liberty to seek help from a GP in another practice. And if you need help in finding another practice, then you can approach the CCG, the commissioning group, to your local commissioning group to find a practice where there is somebody who does have an interest in menopause. The other option is, of course, to get referred up to a menopause service. Now, again, they're not always easy to access, and there have been delays in getting appointments due to COVID. And it's frustrating to say this, I think we're all finding that some women, they're having to be very determined to get the help that they need, they deserve, and should be accessible to them a lot easier. So I'm sorry for that. And we, as the British Menopause Society, working with the Department of Health, are trying to improve on that situation and improve resourcing within this area. But please don't take no for an answer.
I think that's brilliant advice.
Sally, Nick, can we ask this question? For those women, do hormone-related heart palpitations tend to get better post-menopause? We've had this one before, so we're keen to hear what you think.
They do, they usually do. And if it's not settling, then it's important to see your GP or even get referred to a heart specialist to investigate that. But initially, it is a very common symptom of the menopause and tends to be associated with those periods of flushing and sweating. It's a feeling that your heart is racing. And that's one of the things actually that hormone therapy can treat very well, that if that is happening along with the hot flushes and sweats, then stabilization of the hormone fluctuations that trigger those symptoms can certainly be helpful. But if the symptoms aren't settling, it's important that additional advice is sought by performing an ECG, for instance, just to be on the safe side, to make sure nothing else is being missed.
Thank you. And one of the following questions was, are there the same dangers around taking HRT as there were?
Well, we're striving to optimize the benefits and minimize side effects and risks with hormone therapy. And I think one of the mistakes that we made in the past was starting on higher doses of hormone therapy that perhaps were more likely to give side effects and more likely to increase risks. So what we try to do now is start lower doses, use hormones which are body or bioidentical, so they mimic the effect of hormones that the ovaries would naturally release. And by doing that, metabolically, and from the side effect perspective in general, actually, these preparations are much better tolerated. And we're looking at preparations in the future that could potentially even reduce the risk of breast cancer, because in the past, people have been concerned about increases in risk of breast cancer. But we know that there are differences between different types of HRT in terms of the impact on the breast. And these body identical hormones or biosimilar hormones seem to be more gentle, if you like, on the breasts, and potentially associated with lower risks. So minimum effective doses and using the right sort of hormones. And yeah, I think we're making great progress.
Thank you. One that's come through, which I know we've had a few times, is how long can I be on HRT? I started at 57, and after a year and a half, my GP said he wanted to take me off due to my age, to my horror, which was why I'm currently resisting.
So the guidance from the hormone therapy perspective, and from, in fact, the International Menopause Societies and the British Menopause Society, is that we don't put arbitrary limits on duration of hormone therapy usage. So it's all about individualizing. And some women will never need hormone therapy. Otherwise, other women might need it for a lifetime. And for the majority of women, what we're doing is assessing their risks on an annual basis, weighing up the pros and the cons. So if that individual has symptoms which are persisting, even into their 60s, then what we might do, rather than stopping treatment abruptly, is reduce the dose and seeing how they get on with it. But if they still need it, if they have a return of symptoms, they should be allowed to continue with it. One thing that we have to be cautious about is that women in their 60s, 70s, and 80s don't need the same doses of hormone therapy as women do in their 30s, 40s, and 50s. So what we have to do is tailor-make the treatments that we're using to maintain safety. And that's what we do. We tend to bring down the dosages if we're prescribing in an older age group. But I see so many women in my clinic that come along because they've been arbitrarily just taken off their hormone therapy. They feel absolutely terrible. And what they're looking for is advice that they're not being irresponsible to continue with the treatment, which usually they're not. You know, it's the pros outweigh the cons for them to continue with it.
Thank you very much, Nick. I'm afraid we've come to the end. We may carry on for a couple of moments. I know your book's just been republished. Could you show us the cover so we can screenshot it because I know we'll get the question afterwards. Managing the Menopause, from the President-elect of the International Menopause Society. So is that available on Amazon or through bookstores?
It is available on Amazon. I would say that it is written primarily for healthcare professionals, but many women, I think, would get a lot of information out of this book that would be useful to them. And so that's why I'm recommending it to everyone, really. If there is some technical jargon that perhaps needs to be explained, then we as healthcare professionals are there to do that. So, yeah.
Thank you. Well, whoever wins the goodie bag and that wonderful consultation with you will also get a copy of the Plain English Guide to Menopause. So worthwhile getting the two as a bundle, I suggest.
Something for everyone, totally, absolutely.
And thank you very much, Nick. As always, it's an absolute pleasure, and we hope to see you again here. And some very nice comments about what you shared with us today. So thank you very much. And some lucky person is going to be receiving a consultation with you. just before. Well, we'll do the draw afterwards, so maybe it was somebody that's asked us a question today. But of course,
thank you, Deborah.
You can get a consultation through Hormone Health, can't you? Is that hormonehealth.co.uk?
That's right.
Fabulous.
Thank you very much for giving me the opportunity to share some time with your wonderful audience, and I hope to be able to do it again in the future. Sally, thank you very much.